A very good morning to one and all present here. I'm Dr. SOMANATH Sharma, representing Department of Urology, Stanley Medical College. I'm here to present a paper on is it high time to redefine the gray zone of serum PSA in Indian population to decrease the burden of trust-guided biopsy, our institutional review. So to begin with, serum PSA has been used as a diagnostic marker of CA prostate since its discovery. The incidence of CA prostate is higher in Western countries when compared to the Asian population, and also similarly the cancer detection rate in India is much lower than Western counterparts. The reported cancer detection rate of trust biopsy is around 30% in Western countries, and it is much lower in Asian countries, including India. Hence, a large proportion of patients in India undergo unnecessary biopsies. So, the aim of this study is to find out the cancer detection rate of trust-guided biopsy in Indian population in the standard gray zone levels of serum PSA. Materials and methods. This was a retrospective study conducted at Stanley Medical College. From March 2018 to May 2020, 125 patients were included in this study. Inclusion criteria: all symptomatic patients who underwent trust-guided biopsy for the indication of raised serum PSA level between 4 nanogram to 20 nanogram per ml, irrespective of DRE findings, were included in the study, and patients with any recent history of UTI, AUR, urethral catheterization, or instrumentation, and on 5-alpha reductase inhibitors were excluded from this study. Materials and methods: a standard 12 Gore biopsies were taken in all cases using end-firing transrectal USG probe. All patients had antibiotic prophylaxis. The patients were categorized into A, B, C, and D corresponding to PSA levels of 4 to 6, 6 to 8, 8 to 10, and 10 to 20. And each group was statistically analyzed. The age, the prostate size, and PSA between benign and malignant disease were compared using Mann-Whitney test and Hyox. A median calculator was used to calculate the medians, and WebInfo developed p-value statistical tool software was used to determine the p-value, and any p-value less than 0.05 was considered to be significant. Our observation: out of 125 patients, 23 patients had malignant disease. The remainder 1 or 2 had benign disease. The median age group in all patients was 65 years, and median age of malignant disease was 64.5 years, and median age of benign disease was 65 years. The median prostate size of all patients was 50 grams, whereas in case of malignant disease it was 40 grams, and in benign disease it was again 50 grams. The total PSA levels were monitored in all patients with the median of 24.48 nanogram per ml. In case of malignant disease, it was sitting at 77.90, and in case of benign disease, it was sitting at 16.80 nanogram per ml. So in group A, out of 35 patients, 35 had benign disease, and group B, out of 23 patients, 23 had benign disease, and out of 21 in group C, 20 patients had benign disease and one turned out to be CA prostate on trust-guided biopsy. And in group 4, that is group D, out of 46 patients, 20 patients had malignancy and 26 had benign disease. So the overall cancer detection rate was 18.4%. The cancer detection rate in group A and group B was 0% and 0% respectively. And in group C and group D, it was 4.76% and 43.47% respectively. There was no significant difference in the age group between benign and malignant disease. Patients with malignant disease had significantly smaller prostate, 40 versus 50, with a p-value of less than 0.001, which was statistically significant. The studies from India: what does the studies from other studies from India say? Agarwal in 2004, with a sample size of 472, had an overall detection rate of 34.6%, with a PPV in gray zone area of 28.3%. Agnihotri in 2014, with a sample size of 873, had an overall cancer detection rate of 29.7% and a PPV in the gray zone at 15.2%. Chavan in 2017 had a sample size of 440, where he had an overall cancer detection rate of 8.7% only, and positive predictive value in the gray zone area was 2.3% only. They had suggested that raise the serum PSA cutoff for trust biopsy to 5.4 nanogram per ml in Indian population to avoid 10% of the unnecessary biopsies. Other studies from India, Jain recorded a statistically significant rising incidence of CA prostate over time. The annual percentage change in Bengaluru was 3.4 percentage, and in Chennai was 4.2 percentage, Delhi 3.3 percentage, and in Mumbai it was 0.9 percentage. So Chennai is on the rise. The rising trend of prostate cancer may be due to increased migration of rural population to urban areas, and adaptation of Western lifestyle, increased awareness, and improved access to medical care. These are all the various studies. What does the studies from other countries say? At Singapore, with a sample size of 804, overall cancer detection rate was 27.6 percentage, and PPV in 4 to 10 range 4 to 10 nanogram, the gray zone area was 20.9 percentage. In Spain, the PPV in gray zone area was 29.2. In America, out of largest sample size 62,537, the overall detection rate was 38.3, and PPV in gray zone area was 25.3 percentage. And ironically, among Asia, Japan has the highest CA prostate detection rate and incidence. Many contemporary studies from other countries and all over Asia indicate that Asian population have a very low trust biopsy yield as compared to other continents, especially for serum PSA values less than 20 nanogram per ml. Conclusion: as our study is not a population-based study and limited to a single institution, we cannot draw direct conclusions about the changing status of the demography of prostate cancer and the prevalence of cancer in Indian society. Currently, a single demarcation between normal and elevated PSA values, 4 nanogram per ml, is used as an indicator for biopsy among men of all ages in our country. Hence, increasing the present serum PSA cutoff for trust biopsy in Indian patients may help in avoiding unnecessary biopsies. The limitations of our study are that it is limited to a single institution and it is retrospective in design. Further studies from various regions of India may help in the creation of a regional database of biopsy outcomes in Indian males and will help in guiding Indian urologists and patients and allowing them to make an informed decision about outcomes and complications. These are all my references. I'd like to thank the TAPASU for this opportunity. Thank you.